All right, well, good morning. Glad everybody could join us today. Welcome to this February 2017 UTMB NASA JSC Aerospace Medicine Grand Rounds. Thank you to those of you joining us here at USRA in Houston, and to those of you joining us from our satellite locations and streaming live online. And we're glad that everybody could join us today, including one of our speakers that I gave the wrong directions. After 4 years of doing this, I gave the wrong directions, and he actually listened to them. But he made it. That'll show you to listen to me. So, okay, well, without further ado, I would love to introduce our two speakers today. We're really privileged to have Dr. Lawrence Rice and Dr. Ibrahim, who will speak to us about spaceflight anemia and clots in space. Dr. Rice graduated from Emory School of Medicine in 1974, completed internal medicine residency and hematology fellowship at Baylor College of Medicine in Houston, then served on the full-time faculty at Baylor for close to 30 years. He was the hematology program director and rose to the ranks of professor of medicine and professor of thrombosis research. His primary affiliation changed in 2007 to Chief of Hematology at Houston Methodist Hospital and Professor of Medicine at Weill Cornell Medical College. He has maintained a very active consultative hematology practice at Methodist for more than 35 years. The practice is distinguished by the breadth of blood disorders managed, including many cases yearly of relatively rare disorders such as congenital TTP, paroxysmal nocturnal hemoglobinuria, and Evans syndrome. Dr. Rice actively teaches subspecialty fellows, medical residents, and students, and has received numerous, and might I say numerous, outstanding teaching awards. He has published more than 100 peer-reviewed manuscripts and a few dozen textbook chapters and monographs. His research interests include thrombocytopenias and anemias. Dr. Ibrahim is a graduate of the Bachelor of Science in Bioengineering from Rice University. He then got his MD degree from the University of Texas at Southwestern in Dallas. He finished an internal medicine residency and hematology oncology fellowship at the University of Texas Southwestern in Dallas. And he, since September of 2014, has been hematology faculty, the Division of Hematology at Methodist Hospital in Houston. His current projects include a pilot study investigating the utilization of microvasculature microscope to characterize flow dynamics in patients with sickle cell disease correlated with clinical presentation. Dr. Rice.
Happy Valentine's Day. I hope you all are prepared for the flood, Valentine's Day flood. So you all can hear me okay. You all know that every astronaut, cosmonaut who's been in space for more than 3 or 4 days comes back anemic. They lose 10 to 15% of their red cell mass. And my colleagues and I have believed for a long time that this anemia is far from benign. I, for a long time, kept a scrapbook, and it was curious to me that virtually every time the shuttle landed, there'd be articles like this in the newspaper. Astronaut is stunned by how weak he is. And as many of you know, many returning astronauts are orthostatic, dizzy, have trouble even walking, many of them, for a week or even more after their return to Earth. And it was surprising because why don't they ask the other astronauts who've been up there? They could have told them that. Although I've heard some astronauts brag, oh, I wasn't weak. But a good half of them are very orthostatic. And we believe a lot of this is due to spaceflight anemia. In fact, some of the problems with osteopenia and muscle mass, etc., we think relates to vascular flow, perfusion, anemia problems. The mechanism of spaceflight anemia was debated for 2 or 3 decades, and there were various theories about oxidant damage to red cells and production problems, etc. And Clarence Allfrey, my senior colleague who passed about 3 years ago, and I and our other colleagues, I think figured this out based on studies we did on SLS-1 and SLS-2. On these 2 space life science missions, we performed ferrokinetic studies on astronauts on one of the missions after 1 day in space and another mission after 3 days in space. And I don't have time to go into detail. In fact, this is going to be a fast-paced presentation. I don't have time to belabor a lot of various details that are interesting. But suffice it to say that our studies showed unequivocally that during the first few days in space, a time when our studies show that the red cell mass is declining by 10 to 15%, red cell production was absolutely normal. So red cell mass was declining, but red cell production was absolutely normal. And again, I don't have time to belabor this, but this is a very important slide. This is key to what came to be our understanding of what's going on. So on these 2 SLS missions, we labeled astronauts' red cells with chromium 12 to 14 days. On one mission it was 12 days, on another mission it was 14 days before launch. And we had them come into our lab, and during the week or 2 before launch, we traced an absolutely normal red cell survival curve. Then the spaceship went up, and one would think if you're making red cells normally, but the red cell mass is falling, then you must be destroying your red cells. But what we saw instead was the survival did not decline. And in fact, in every single astronaut, this curve is supposed to be the sum of several astronauts, but the truth is that every single astronaut had exactly the same pattern. It looked like the red cell survival was increasing. The cells were surviving longer than normal. And as I'll show you, this appearance of prolonged red cell survival is an artifact of the fact that unlabeled red cells were being destroyed, so the concentration of the labeled red cells was increasing. So the paradox we faced initially was red cell mass reproducibly falls 10 to 15% in the first few days in space. Red cell production is normal during this time, and red cell survival was also normal, or actually appeared supernormal based on the graph I showed you. And I've been teaching students and fellows and physicians for decades that the only way you can become anemic is you either don't make red cells or you lose or destroy them. But here they're making red cells, they're not destroying them, and yet they become anemic. So how could that be? Well, I kind of already told you. The only possible explanation is that in the first few days in space, the young red cells, the red cells that were made after we labeled their red cells with chromium, so the red cells they made in 12 to 14 days before launch, those were being selectively destroyed. So when they came back to Earth, we found that old red cells survived normally. They had the same number of old red cells as we would expect. And the red cells they made in space, they had the right number of those. They were making red cells while in space. But it was the cells that were made in the few days before launch that had been selectively destroyed. And that was a surprise because no one had ever dreamed of a mechanism whereby young red cells could be selectively destroyed. In fact, hematologic dogmas, I think it's the next slide, were that there's no normal way to destroy your red cells once they're released into the blood. And that red cell mass is controlled at the level of production. So again, 10 to 15% decline in red cell mass, survival's normal, young cells are selectively hemolyzed. We name this process neocytolysis. And we thought this was due to EPO suppression. I'll show you in a little while that there's some data that perhaps hypoxia-inducible factors might be, which also control EPO, might be more important. So what happens is, here on Earth, 20% of our red cell mass is kept in our arms and our legs by gravity. But as soon as you go into microgravity, this 20% pools centrally. Gravity's not there to pull it into your arms and legs. And you have acute central plethora. And in the first 24 hours in space, about 20% of your plasma is transidated into the tissues. And every astronaut will tell you that after 24 hours in space, their chest wall, their face gets puffy, while their arms and legs look shriveled up. I used to, if I had time, I'd show you pictures of that, but this is well known. That the mechanism by which 20% of your plasma translates into the tissues is unknown. But then, over the next few days, there's destruction of the red cells because of this acute central plethora to give you a situation which is more adapted to life in microgravity. The problem is that when you return to 1G, when you return to Earth, suddenly you're hypovolemic and you're anemic. And as I said, orthostatic. So what can you do about that? Well, you can water load, and astronauts know to hydrate when they're getting ready to land. But that does not correct the whole problem. It's like you were phlebotomized 1.5 units of blood over a few minutes right before landing. So the theory we came up with is that young red blood cells can be selectively hemolyzed when there is an excess. And this allows rapid adaptation to new environments that I'll go over. We thought this process was probably initiated by EPO suppression. It's limited to reducing the red cell mass by 10 to 15%, so it allows rapid adaptation. And we thought this process also was important to normally regulate the red cell mass, so that red cell mass is not only controlled by how many red cells you make, but there's some degree of neocytolysis that occurs normally. And I've already said this flies in the face of previous hematologic dogmas. And the dogma is that the kidneys sense oxygen delivery and how many red cells are in your body, and makes either more or less erythropoietin depending on what's going on. And this affects how many red cells you make. Well, if this were the only way that red cell mass was controlled, any adaptation to a new environment would be interminably slow, because red cells live 120 days. And if you stop making them completely, it would take a good while to lower your red cell mass when you were in a situation where that was desirable. The hematologic dogmas also held that erythropoietin was the most specific hormone in the body, and that the only cells it acted on were red cell precursors at these stages and prevented the apoptosis of red cell precursors. We now know that there are erythropoietin receptors on a number of cells and a number of different tissues, and our theory holds that there are actions of erythropoietin controlling the survival of young red blood cells. Now, how could that be? Do red blood cells have EPO receptors? Circulating red blood cells absolutely do not. But I'll show you that this action of erythropoietin is indirect, and I'll show you what our theories are and what the evidence is. So at 8 o'clock in the morning, and with the storm coming in, and with the amount of time I have today, it would be impossible for me to go through this in detail. This is from our Lancet paper, 1997, where we elucidated this theory of neocytolysis. And panel 1 shows the traditional concept that EPO acts on early red cell progenitors and either causes them to survive, or in the lack of EPO, they apoptose, and that's the way red cell mass is controlled. Note that already committed red cells are not affected by EPO, so if you shut off EPO completely, you would continue to make new red blood cells for about a week, because it takes a week for committed red blood cells to egress from the marrow. Our theory held that there are also effects of EPO on macrophages and the interaction of red cells and macrophages. And in the presence of EPO, red cells survive. In the absence of EPO, young red cells get destroyed, and eventually a new equilibrium is reached. So I've already said this helps to regulate red cell mass. It allows rapid adaptation. I'll come back to newborn polycythemia a couple of times very briefly. And our theory supports the idea that erythropoietin and hypoxia-inducible factors are the main regulators of the red cell mass. And our theory helps to explain a lot of unexplained things in hematology. So when we proposed our theory, there were a lot of skeptics and non-believers, and perhaps there still are some. But when we thought about this, we said, well, you know, this should not only apply to astronauts. If people live at high altitude, or if mountain climbers go up to very high altitude, they become polycythemic due to the low oxygen tension. And then if they descend, they should have the same process. They have an inappropriately high red cell mass for their new environment. It should precipitate neocytolysis. In renal failure, there's EPO deficiency. We thought that neocytolysis could contribute to renal anemia. We thought it had implications to blood doping, and the U.S. Anti-Doping Agency agreed with us and supported some of our research. Why does this mechanism occur? Well, again, I said it allows rapid adaptation, but I don't believe, and I don't think you believe, that either God or evolution care about whether astronauts are dizzy or whether people who descend from high altitude get dizzy and don't feel well. But I think this mechanism arose because when newborns emerge from the mother, they are polycythemic due to the hypoxic uterine environment. And the most problematic day of survival for humankind, and probably all animals, is their first day of life. The second most problematic day of survival is their second day of life. So in order to optimize your chances for survival, I believe that this mechanism rapidly lowers the hemoglobin to improve blood flow in the normoxic environment. So I believe this is why this mechanism arose in evolution. There are potential implications to a number of blood disorders. So we wanted to prove our theory. And we said, well, if this should occur at high altitude, let's go to high altitude and study it. So a younger me, Clarence Alfrey, was a remarkable man. He was the principal investigator on many of these studies. Former president of the Harris County Medical Society, a brilliant man, and as I said, passed 3 years ago. His wife, Maureen, some of our other collaborators in the mountains of Peru. So we went to Cerro de Pasco, Peru. This is a first grade class in Cerro de Pasco. It's the largest city in the world at 14,000 feet or higher. It's 14,500 feet. The reason these children have these rosy cheeks is because their crits are in the 60s. The ambient oxygen tension is about 60. So we studied originally 10, but one of them was a carpenter and drank a lot and didn't show up to some of the experiments. So we had 9 analyzable subjects, normal volunteers. And we studied them in a number of ways at sea level. I'll tell you a little bit more about that. And then we took a bus to Lima. It's about an 8-hour drive from 14,500 feet to sea level. And we studied them for a week, 10 days at sea level, and showed that their red cell mass fell just as we predicted by about 10%, just like happens in astronauts. And this was accompanied by markers of hemolysis. And as we predicted, the reticulocyte count was normal in these people when they went to sea level for several days. It didn't decline until about 8 days later, as we would predict. Oh, I'm sorry. We found these same things, but before we went to Peru, we looked at the literature, what was known about these things that we were going to investigate. And we were amazed to find that a lot of the things we intended to study had already been studied and reported. And Dr. Marino wrote several papers around 1950. Dr. Huff and Finch from Berkeley and the University of Washington had already done some studies, and their studies had already found some of the things that we were going to investigate, yet their observations had been pretty much ignored. One of our subjects, we actually measured red cell mass in every subject in 3 different ways. This is a carbon monoxide rebreathing apparatus. We did chromium labeling. We did carboxyhemoglobin studies to measure red cell mass. And I am running short on time, quicker than I thought. So I'm going to run through a lot of this. You know, as you would predict, serum EPO plunged when we drove these people to sea level. In 3 of the people, we gave them low doses of EPO to maintain their serum erythropoietin level in the normal range. And as we predicted, red cell mass fell by 10%. In people given EPO, the red cell mass did not fall. 2 of the people had blunted responses for reasons I could tell you after the talk. When we took them to sea level, there was a very rapid rise in their ferritin levels because the red cells were being destroyed and their iron was being transferred to stores. In those given EPO injections, there was no such rise. And we showed, again, we measured red cell mass in 3 different ways, that the red cell mass correlated extremely well with the serum ferritin. So ferritin was a handy, easy way to measure these changes. So we confirmed neocytolysis. We also studied neocytolysis in renal failure patients who received erythropoietin, and then the erythropoietin was withheld, and their red cell survival declined, and we had evidence that this was selective for the young red blood cells. We came up with a theory. Macrophages do have EPO receptors, and we thought that endothelial cells have EPO receptors. We thought that EPO affected endothelial cells to influence the interaction between young red cells and macrophages. We showed changes in endothelial cells and macrophages in conditions of high or low EPO. We developed a blood doping model of EPO, again with grants from the anti-doping administration. This white bar is me. And this is my ferritin before I gave myself daily EPO injections for a month. And at the end of a month, my hematocrit was 54, and my ferritin was down here, and we stopped the EPO, and there was a rapid rise in ferritin, indicating, along with the decline in hemoglobin. We also studied cell surface markers. We didn't get very far with our surface marker study because the PI, Dr. Chang, his wife said he wasn't making enough money, so he resigned from academic medicine and went into private practice. But we did get some preliminary results that there were changes in surface markers. And these observations have been confirmed by others. Angela Riso in Italy published a number of studies showing neocytolysis in mountain climbers descending from high altitude, and showed that phosphatidylserine and CD47 were critical markers. There's another European group that much of their data is not yet published, so I couldn't go into detail if I wanted to, but they have models of how EPO affects phosphatidylserine expression and CD47. But some of the more exciting studies, Dr. Riso has proposed that there may be more than one mechanism of neocytolysis. And I'm going to show you a couple of slides that might support that. And a group from Utah, led by a good friend of mine, Joe Percal, have figured out an alternative explanation for neocytolysis from our model. First of all, their group studied hospital records from 35,000 newborns in Utah and Colorado and found very rapid falls in red cell mass, found evidence of hemolysis, and found evidence to support that neocytolysis was occurring in these newborns. But then they created mouse models of neocytolysis based on keeping mice in hypoxic conditions and then putting them back in normoxia. They also had special inbred mice that had hypoxia-inducible factor mutations or EPO receptor mutations. They treated mice with antioxidants. And they have arrived at a model where in hypoxic conditions, actually you get increased hypoxia-inducible factor, which causes a decrease in catalase, the main protector against oxidant damage. And also there's decreased mitophagy. Reticulocytes do not ingest and destroy their mitochondria the way that they should. So red cells made in hypoxic conditions have an increased mitochondrial mass, decreased catalase, and when they return to normoxia, there's oxidative destruction of these primed young red blood cells. Now, the problem with this model for us in this room is that their data is very convincing. If you are studying hypoxic mice or newborns or descent from altitude. But astronauts are not hypoxic. And this model does not really explain what goes on in astronauts. So perhaps there is more than one mechanism for neocytolysis. So certainly more research needs to be done. And thanks for your attention. And Dr. Ibrahim is going to speak, and then we should have time for questions for both of us.
Can you hear me? There you go. All right. So we're going to change gears a little bit and talk about a topic that there's actually not much data on. Remarkably, there's no known reports of any astronaut or anyone that's had a human space flight that's developed a thrombosis. So I'd like to talk a little bit about some potential risks of thrombosis and space flight, but kind of focus on the data that we do have on specifically air travel. I found this picture interesting because it was in the British Medical Journal in 2012, and it was regarding the potential for space travel among civilians. And this is a burgeoning field that potentially will have implications in the coming decades. I know Ellison Field is one of the sites for commercial space flight, but it brings in some questions about, are we ready for commercial space flight with average human beings that aren't superhuman astronauts that are in the best shape possible? So most of the talk is going to be focused on travel-related thrombosis and what the data shows. Some of the data is fairly conflicting, especially when it comes to teasing down the mechanisms of the causes of thrombosis in air travel. The first person to publish and describe thrombosis in air travel was John Homans, who's a surgeon from Massachusetts General Hospital in 1954. The patient that he described was a physician who was flying from Caracas, Venezuela to Boston. And this is the first published report of air travel thrombosis. One of the interesting studies that first described this problem was in the 1980s that looked at causes of death in air travel, and they looked specifically at what patients died of and how and what route they were in when they developed cardiac arrest. Interestingly, they looked at would-be passengers, so these are passengers that are waiting at the terminal, and found that the vast majority of the cause of death in those situations were cardiac, like myocardial infarctions. One was cerebral. I think in the study they describe a 20-year-old female that had a berry aneurysm rupture. Two of the patients had respiratory problems, and only one had a pulmonary embolism. Of the 104 cases, only 28 of the people that died were these would-be passengers. The passengers that either arrived and then passed away or passed away in flight were the majority of the patients. They were 61 of the 104. Again, the majority of the cases were cardiac, about 43 patients that had myocardial infarction. But interestingly, the vast majority of those were men. And a significantly higher number of patients died of pulmonary emboli, either en route or after arriving. And the vast majority of these patients were female. They also teased out what kind of flights these patients that passed away from pulmonary emboli were on. And as clearly shown here, the vast majority were on flights that were lasting more than 12 hours. So 10 out of the 11 were on long flights that died of pulmonary embolism. And what they don't show up here is that a lot of these patients had no past medical history either. So more than 2/3 of the patients that they described that died of PE didn't have any underlying medical problem like a malignancy or recent surgery, or these were sudden causes of death. So travel-related thrombosis is a public health issue, and it's something that's been taken up by the WHO. Given the number of passengers that fly each year, it's 2 billion. There's an estimated 150,000 extra cases of venous thromboembolism per year that we could attribute to flying. We know that the acute mortality of venous thromboembolism not related to cancer is 4%. So this is a big public health problem. Controlled studies to look at preventative measures such as prophylaxis with Lovenox, for instance, are scarce. To most of us in the audience, we're aware of Virchow's triad, which looks at kind of general causes of VT, and this was described in the 1850s and has held pretty well. It tells us that stasis, vessel wall injury, and kind of underlying hypercoagulability are contributors to development of thrombosis. A better model, and I'm sorry this didn't show up very well, is Virchow's triad doesn't really tell us when to expect a thrombosis, but we know that certain risk factors like factor V Leiden carry a five-fold increased risk of thrombosis and may increase the threshold of someone to develop a clot. So we know that if someone has multiple risk factors, such as an underlying genetic predisposition, possible oral contraception with high estrogens, these may tip the patient over into developing a thrombosis after, for instance, a long flight. And this is a common theme that we see throughout the studies that we do have in air travel, that multiple risk factors are necessary for a person to develop a thrombosis, and not one particular risk factor alone is necessary. So this just goes to the point that it's an accumulation of risk factors prior to flight. Studies have looked at patients that have factor V Leiden or oral contraceptive use, as well as patients with high body mass index. An interesting study out of the Netherlands that was published in Blood in 2009 looked at calculating the relative risk based on a number of these factors, and they found that the more number of risk factors you had, the higher chance of you developing thrombosis, and these are patients that are had undergone air travel. They saw a nearly 60-fold risk in females that had an elevated factor VIII level, that were also on oral contraceptives, for instance. But it doesn't really answer the question, why does air travel in and of itself increase the risk of thrombosis? There's been a number of studies to try to tease that out to varying degrees of success. Again, we go back to Virchow's triad, and as was observed by Holman, a prolonged immobilization and sitting causing stasis is a contributor to thrombosis. And this has been described in other settings. Recently, in the past decade or so, there's been a lot of case reports looking at patients or people that have been sitting for prolonged periods of time in front of a computer, playing a video game, and have developed thrombosis. This has been especially well described in Korea. So we know that immobilization in of itself is definitely a risk factor. Specifically with regards to travel and air travel, there have been studies that have found that a person's height does put them at a risk of thrombosis. They found that in this particular study that patients that were taller than 1.9 meters were at a 9-fold increased risk compared to average height people who did not travel, and this is thought due to being in a cramped position. We also know that where someone sits on an airplane has an impact of whether or not they develop thrombosis. So we know that patients that sit closer to the window seat are less likely to move about and may develop thrombosis as well. Shorter people, patients that are less than 1.6 meters, in this particular study were found to have a 5-fold increase compared to average height individuals. And this is thought, since their feet can't touch the floor, the popliteal vein is compressed and puts them at higher risk of thrombosis. So a few studies in the next couple slides try to tease out the mechanisms of travel-related thrombosis. This particular study, also from the Netherlands, looked at measuring specific coagulation factors and factors related with thrombin production to determine if they were activated in air travel. And they took 71 young volunteers, and it was a kind of interesting study because they used the patients as controls for themselves. But the 71 patients were exposed to 8 hours of air travel in a commercial plane. And they also had 2 control exposures for the same patients, where they either sat in a similar seated position in a cinema for 8 hours watching a movie, which sounds like a lot of fun, and then 8 hours in a daily life situation, sitting at a desk or doing something like that. And they measured thrombin formation in each of these specific situations, both before, during, and after. And they found that individuals that were on flight specifically had 17% of these individuals that were on flight specifically had elevated levels of thrombin production, compared to only 3% in patients that were just watching movies, or 1% that were just doing their normal life situation. So this pointed to something inherent in air travel specifically that increased markers of thrombin production. But again, that doesn't pinpoint to the exact cause. We know that there are a number of factors that occur in air travel. You're dealing with a situation where you may be dehydrated due to increased alcohol consumption, lack of free water accessibility, caffeine ingestion. There are viruses all around in the air, stress, air pollution. And these were all looked at specifically in that same cohort and published in a later study. And what they found were suggestions that the low oxygen tension in the air cabin was a possible contributor to increased thrombin formation. So this led to a more detailed study trying to isolate whether prolonged immobility or profound prolonged hypoxia affect blood coagulation. And this was done with the European Space Agency. And they looked at this was actually 2 different studies. The first study looked at adult women. It was known as the Y study. And they took 24 healthy women, placed them in a supine position for 60 days. This was thought to mimic the microgravity environment, having a person placed in -6 degrees in a supine position for a prolonged period of time. The other study looked at men that were at the Concordia station in Antarctica, and these people experienced severe continuous hypoxia. They were there mainly to study the aspects of social isolation in Antarctica for space travel. And they took blood samples at baseline prior to their immobility or prior to their departure to Antarctica, as well as throughout the experience and then after remobilization. And they also checked markers of thrombin formation, such as the D-dimer and prothrombin fragments. And they found no increase in coagulation markers in either environment. And these were very high stress environments, so if these factors did have an influence, they should have had some impact on thrombin formation. I'm going to change gears a little bit and just focus on a study that was published in the past few years looking at the effects of microgravity on platelet function. Specifically, there are a number of scenarios where we suspect microgravity or high gravity situations result in thrombosis and hemorrhage. One of them is an incident that happened on the Apollo 15 space program, where 2 of the astronauts developed numbness and swelling in the fingertips. One of the astronauts developed a brief momentary loss of consciousness, and when he came back 21 days later, developed an acute myocardial infarction on Earth. There was a thought that this was perhaps due to issues with their spacesuits and regulation of fluids at that time. There was also some issue thought related to magnesium loss, but that pointed to the possibility that perhaps there was something else at play. And that's the closest we've come to any sort of possible thrombotic event being related to microgravity. Another study called the Cosmos studies looked at rats that were placed in microgravity for 14 days. And when the rats were brought back to Earth, developed diffuse thrombi in several cases. A lot of roller coaster, or there are about 4 roller coaster deaths in the US. Half of them are related to hemorrhage and thrombosis that seem unrelated to the actual ride and happen afterwards and are not explained well. And then thrombotic complications have been described in air crews that are undergoing training that are exposed to high G forces. And this study tried to elucidate the mechanisms of that. We know that platelets are very important in thrombosis and hemostasis. They work on a number of different ways, specifically the interaction of the GP1B receptor on platelets and von Willebrand factor, which is secreted by endothelial cells. The specific study looked at simulated effects of hypergravity and microgravity, and they used mice. In this particular figure, they looked at the bleeding times for mice that were either at the control 1G or 8G, and they found that bleeding times on average, or median bleeding times, excuse me, were less for mice that were exposed to 8G forces compared to the controls. And then in a simulated microgravity environment, the mice were noted to have longer bleeding times as compared to the 1G controls. They tried to look at this at a more molecular level and looked at the expression of the glycoprotein 1B alpha surface expression on platelets. And they found that in the microgravity environment, that the expression of the platelets was significantly less present in the simulated microgravity environment. And in the hypergravity situation, had a significantly higher expression of the glycoprotein 1B alpha. So as I stated, GP1B expression appears to decrease with microgravity and increase with hypergravity. We know that, and I didn't include the pictures, but in one of the ancillary studies, they found that an interaction with glycoprotein 1B alpha and with the cytoskeleton was positively regulated with gravity. How gravity regulates this interaction is still unclear, but it appears that platelet functions is inhibited by microgravity environments and activated under high G conditions. Perhaps this is why we haven't seen many thrombotic complications in our astronauts, but that's a potential avenue for further research. So some of the take-home points I wanted to point out were that travel-associated thrombosis is due to a combination of risk factors, individual versus cabin-related factors, but it seems that the former individual factors play a bigger role. Platelet function appears to be inhibited by microgravity, but further studies are needed. We do know that granulocytes and their function also are important in thrombosis, and they appear to be inhibited and have been looked at in studies in microgravity as well. And then kind of one thought to ponder is, as commercial space flight becomes a reality in the coming decades, will we need to take special precautions to mitigate for thrombosis risk? So at this time, I'd like to conclude and take any questions for either myself or Dr. Rice.
And thank you, Dr. Rice and Dr. Ibrahim. So we'll look for questions coming from the satellite locations first. Any questions out there? A couple of potatoes will come into the room here now. Do we have any questions for Dr. Ibrahim or Dr. Rice?
Thank you both very much. So what is your answer to the last question you posed? Commercial space travel, and do we have to be concerned about
mitigating
thrombosis?
the risk?
Yeah.
Well, I mean, I think I would take the same approach that the national guidelines take for patients that have air travel. We know that patients that have high risk, and I alluded to some of those, such as genetic factors or prior thrombosis, we do recommend mitigating for that by giving them anticoagulants for limited periods of time. And I suspect, that's the same approach that we would take in that situation.
Hi, thanks. That was a great talk. UTMB is involved in the U.S. Antarctic program. We provide the medical support for the stations. And in recent years, we have seen an uptick in the number of DVTs, specifically at South Pole Station. We've actually seen an uptick in upper extremity DVTs in patients without risk factors. We have seen the increased hematocrit levels that you described in your talk. And I was curious, you had mentioned that one study didn't really find any changes in the coagulation cascade, but I've also read some other literature, specifically in Indian military recruits that are working at high altitude, that there were some changes that may be amenable to homocysteine lowering therapies. Have you read anything similar to that, or could elucidate as to what might be the cause of that we're seeing at the South Pole?
Yeah, and I haven't come across that particular study with the Indian military, but that's interesting that it's in the upper extremity. I know it's described, as Dr. Rice pointed out, that the fluid shifts in the microgravity cause a proportion of fluid to go up into the upper extremities, and I did come across that in my review, but not specifically with regard to homocysteine levels.
With regard to commercial spaceflight, one of the reasons we probably never had problems with DVTs or thromboembolic problems in space is one part of that triad's missing, the stasis part. And even when they're on the pad for quite a while, now everybody's kind of laying flat with their legs up in the air. But on the other hand, when Jim is going to be flying people in, say, Virgin Galactic or commercial spaceflight passengers, probably 40–50% are not even from the United States. So they're going to be coming here on maybe some of those 10, 12-hour flights. My concern would be that we might fly someone who already has a DVT. That it's not the flight itself is the problem. It's how they got to where you are to do the flight. Is there anything, people that come in with these long flights, is there anything we should do to screen them before we let them go up in suborbital or short-term space flight?
I mean, there have been prior studies that have come across maybe 15 years ago or so that have looked at doing screening Doppler ultrasounds in patients pre and post-flight. The studies are conflicting, but the take-home message seems to be that patients that are at high risk, meaning those that have high risk factors, and I allude to the study from Blood in 2009 to look at those specific risk factors that we know are related, but perhaps those patients that have those higher risk factors should be screened.
I had a quick question about the spaceflight anemia. So in neonates at altitude, do they retain their polycythemia? Kind of the first question. And the second question, to kind of elucidate the mechanism in astronauts, in populations that have restricted blood flow to the kidneys, not hypoxia, but just restricted blood flow, like like FMD or renal artery stenosis, do they have polycythemia? And if you were to correct that, would they undergo neocytolysis?
I'm sorry, I didn't catch the first.
Oh, sorry. Neonates at altitude, do they retain polycythemia after birth?
Actually, I don't know the answer to that. You would think they would. You would think they would if they're still in a hypoxic environment. So again, I'm not aware of data on that particular fact. Although, so the study that was done in Utah, many of those people live at high altitude. It was a Utah-Colorado study, and they did see neocytolysis. But I suspect the environment in Utah and Colorado they were born into was not as hypoxic as intrauterine. As far as the second question, there are reports, it's not extremely common, but there are reports of things like renal artery stenosis causing secondary polycythemia due to renal release of erythropoietin. And it has not been studied, but I would certainly think that if you correct the stenosis, you would precipitate neocytolysis.
Thanks for that talk. That was great. Again, another question about neocytolysis. So, one of the analogs that is used to study fluid shifts is bed rest studies. Do you know? Is there any data on this phenomenon in those studies?
There is, but no offense to anyone involved. I'm not sure the evidence is of very good quality, and first of all, there's very few subjects. The data is very limited. When I read some of that literature, I couldn't show off firm conclusions to sum up my view of it.
So one question for each, for Dr. Ibrahim. So we screen out coagulopathy or coagulation disorders. Astronauts in space are anything but static. They're actually pretty dynamic. There's not pressure against the venous systems and whatnot. And we don't think we have particular endothelial damage. So how would you study coagulability in space to allay our fears that there is a problem? I'm not convinced that we should consider it a problem of coagulability or thrombosis.
I mean, there was a study that I didn't include here that was from Germany where they looked at plasma viscosity in patients at different altitudes. These were healthy volunteers as well, and they didn't find sort of any effects due to altitude or low oxygen tension. But that was one avenue of testing. They used both testing for plasma viscosity as well as doing ultrasounds as well to look at venous diameter and didn't find any sort of precipitating cause from either altitude or low oxygen tension. But that was one method of testing for elevated viscosity.
So again, I'm thinking about how do we rule this out as a high risk for thrombosis, which seems to be the tendency, which I don't see evidence for. You think doing that would allay our fears? And if not, what about bleeding time?
So I mean, the bleeding time, that was included in the study on the mice, and it's usually not. I would say would not be my preferred method. The D-dimer test would probably be a good screening test as far as a high negative predictive value for allaying fears, but that would kind of be my suggestion.
Okay. And for Dr. Rice, you'd mentioned that there seemed to be a 10% limit on the extent of RBC destruction from neocytolysis. Is that independent of, say, what altitude people come down from to sea level? The degree of hypoxic stress, is it always seem to be limited to 10%, or is there any variability in altitude reflected in that?
In the altitude, well, we believe it's limited to 10 to 15%. And we believe it gives you a degree of rapid adaptation. If you needed more adaptation, your situation's already been improved, and further adaptation could go slower. Now in space flight, it's better studied that, you see, at altitude, you're at 14,500 feet, you come down. It's also been studied in the Himalayas. There's studies from Nepal and Tibet. But we believe it's a 10 to 15% limit. In space flight, astronauts who are up in space for a week or 10 days or 12 days or 14 days, when they come back, their red cell mass is down 10 to 15%. If they're up there for 3 months and they come back, their red cell mass is down 10 to 15%. So they reach a new equilibrium.
Okay, and it looks like we are out of time. Thank you, Doctors Rice and Ibrahim, for joining us and for giving us great talks, educational talks this morning. And thank you all for joining us. And again, we'll see you next month in March. We're going to have Dr. Jim McKeith, who is the Chief Medical Officer for the Center for Polar Medical Operations, who's going to give us an update on operations in Antarctica and particularly talk a little bit about recent medevac from South Pole. So join us then. Thanks.